Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated.
Bonjour, bienvenue, tout le monde. Welcome, hello everyone. My name is Doug Archibald. I'm the Director of Research for the Department of Family Medicine, and it's my pleasure today to moderate the Research Grand Rounds, our April version. And it's also a pleasure today to introduce our speaker, Saredo Mohamed Bouraleh. Actually, I could introduce her, but see, Claire Kendall is on our rounds this morning, and Claire was Saredo's supervisor. So maybe it's more appropriate for you to introduce her, Claire.
It would be such a pleasure too. We were so lucky to have Saredo working on our team for 2 years. She was an exceptional master's in epi student who graduated last year. You'll be hearing a little bit about the project she was working on. What you won't hear is all the background of the incredible amount of work she had to do to get the data ready. We thought this was going to be an administrative data study, and we're funded to do that. Doug, you were part of that. And then unfortunately, ran into a number of snafus. She had to change her protocol lots of different times to try and tackle this research question. And she's also just a really exceptional person who's contributed a lot to science and medicine pathways and has done a lot of work in her community that has elevated, I think, the way we think about primary care. So really delighted to turn this over to her for her presentation.
Oh, thank you. All right, Saredo, over to you.
Thank you. That was the best introduction ever. I'm gonna have to steal that. But thank you. Let me share this. Awesome. So before I start, I will like to do a land acknowledgement. So I would like to begin by acknowledging that we are gathered on the traditional, unceded, and unsurrendered territory of the Anishinaabe Algonquin Nation. This is the land of the Anishinaabe Algonquin people who continue to live, care for, and steward this territory today. I share this acknowledgement as a commitment to respect ongoing learning and to recognizing the enduring presence and rights and contributions of Indigenous peoples. In my own work, this means being mindful of equity and inclusion and considering how research and practice can better support Indigenous communities and address systemic barriers. So today I will be presenting my master's thesis. First, my name is Saredo Mohamed Bouraleh. You can pronounce my first name as Saredo or Saredo, either or is fine. And my master's thesis was on Ontario's medical schools' contribution to a socially accountable primary care workforce, associations with pursuit of extended training and practice in rural remote areas. I would like to also take a moment to appreciate the funding opportunities that allowed me to continue with this graduate studies, such as the SSHRC, the CIHR, and my own scholarships such as the CGSM and the Bruyère Health Student Scholarship. So for the introduction, we'll have a slight discussion on the family medicine crisis here in Ontario and what is social accountability. Over 1 in 10 residents in Ontario lack access to a family physician, a problem that's likely to double over the next 5 years as fewer new medical graduates are choosing to specialize in family medicine. And those who do increasingly pursue extended training in fields such as emergency medicine or sports and exercise medicine. And we can also see through literature there's a shift towards focused practice. Underserved patients are disproportionately affected by this shortage, particularly through limited access to comprehensive primary care and to services in rural remote communities. Medical schools here in Canada are committed to social accountability mandates. Now, what are social accountability? So this is a social construct grounded in principles of social justice whereby citizens hold public institutions responsible for their action, their activity, and performance in meeting societal needs. In medical education, this means that medical schools have a societal obligation to align their education, research, and training with the priority health needs of the communities they serve in collaboration with either government, health system, or the community themselves. However, limited evidence exists regarding the effectiveness of these type of initiatives. And on top of that, there are key gaps in the data regarding the training and sociodemographic characteristics of Ontario's primary care workforce, leading to the objectives of my thesis, which was to examine how Ontario medical schools contribute to a socially accountable primary care workforce in terms of graduating family physicians who A, pursue extended training, and B, provide care in rural remote areas. Now, I'm not here today trying to convince anyone that extended training is a bad thing. However, while the purpose of this type of training is to prepare family physicians to meet evolving population health needs, including those of underserved communities, its impact depends on the type of training pursued. In some contexts, schools may emphasize extended training in areas such as family practice anesthesia or care of the elderly, which addresses local catchment needs, while others training pathways may draw graduates towards urban rather than rural remote practice. To better serve our population, schools need to consider two aspects. One, ensuring comprehensiveness of care, which is associated with improved outcomes, and two, supporting pathways that encourage practice in rural remote communities. And we'll take 1 minute to just slightly go over the conceptual framework that I introduced in my thesis. This conceptual framework positions that primary care workforce is a product of interacting system-level, institutional, and individual-level factors, grounding it in the principles of social accountability. At the broadest level, we see contextual factors such as health system policies, workforce planning, which may shape the structural environment in which medical schools operate. And these elements may include funding models or training regulations. Now, medical schools are guided by the social accountability mandates. They translate population health needs into institutional strategies, and this process reflects the established social accountability framework, such as the conceptualization, production, and usability model, where societal needs are identified, operationalized through education, and ultimately reflected in workforce outcomes. So these medical schools operationalize these social accountability mandates through admission policies, institutional culture, formal and informal curricula, and training placement. All of these elements shape learners' professional identities, values, and exposure to underserved communities. These combined processes culminate in workforce outcomes, specifically the pursuit of extended family medicine training and practice in rural remote areas. Key indicators in this project of a socially accountable primary care workforce. Importantly, this framework is a dynamic and cyclical. Workforce outcomes inform policy decisions and health system planning, which in turn may reshape the conditions under which medical schools operate. And this also highlights that achieving a socially accountable workforce is not solely an education outcome, but the result of continuous interaction. Now, we could jump in understanding what are the data sources used for this thesis. I used the College of Physicians and Surgeons of Ontario, CPSO, which is a regulatory database of all physicians registered in Ontario since 1910. And this provides physician-level characteristics such as demographic, sex, language of practice, and country of undergraduate medical school, training, so undergraduate and postgraduate medical school, as well as the physician's specialty, registration, whether or not they are currently a resident or they're independently licensed, as well with the dates, and practice. So I can see their practice location, postal code, address. And with that, I was able to link into Postal Code Conversion File Plus, which is a database developed by StatsCan. And this allows me to see the census geography of these physicians' postal code, their primary practice. And at the end, I ended up using statistical area classification type to classify whether or not a family physician is working or practicing in a rural remote region. Now we can jump to the first objective. So objective 1 is on extended family medicine training. For the population, we looked at family medicine graduates actively practicing in Ontario. And when I say actively practicing, these are physicians that were pulled from the CPSO data scrape, and that year was 2022. So they were actively practicing in 2022 with an independent license obtained between July 1st, 1995 and July 1st, 2021. Family physicians who obtained an independent license prior to 1995 were excluded, as this period predates the elimination of a rotating internship program. Moreover, those who received the independent license in 2022 were excluded to prevent incomplete data capture. And on top of that, I also excluded family physicians who obtained an independent license beyond 3 years of completing residency to ensure we capture physicians who followed a somewhat typical uninterrupted training to practice pathway. And this criterion just helps me reduce this misclassification that may occur. And this allows me to also exclude individuals who may have delayed entry due to personal and professional reasons. The outcome is extended family medicine training, which is a broad term to categorize all +1s, as a family medicine program is a 2-year program. And there's many programs underneath this extended family medicine training label. And that could be emergency medicine, family practice anesthesia, obstetric, and enhanced skills. So as you can see here, I listed those programs as those were the programs the most participated or pursued in my study. So we can see category 1 and category 2. Category 1s are those that could obtain a certificate of added competence, while category 2 are just labeled as enhanced skills, such as obstetrics, women's health. One thing to note is that among graduates who enrolled or pursued extended training, 96.9% did so within 2 years of completing their standard family medicine program. And for that, we only included physicians who enrolled or pursued extended training program within the 2 year of completing their standard program. And lastly, the analysis is a multivariate logistic regression model. Now, it's a big table, small numbers, completely get it, but table 1 shows the distribution of family physicians who were actively practicing in Ontario in 2022 that either completed a 2-year standard family medicine program versus those who pursued extended family medicine programs. So between 1995 and 2021, 7,387 family medicine graduates obtained their independent license, where 1,866, which is 25.3%, pursued extended training, while 5,521, which is 74.7%, completed the standard 2-year program. Now, in this red box, what we can see is the languages of practice. Highlighted in yellow are specifically those that went to pursue extended family medicine training. Graduates who pursued extended training were more likely to be bilingual at 27.7%. Then in these red boxes, we have undergraduate and postgraduate medical school. And in those 2 boxes, what I could see, since I know this thesis, is that Queen's University had the highest percentage of their graduates pursuing extended training. Then at this red box here, we're looking country of medical school. So whether they're a Canadian medical graduate or an international medical graduate. And graduates who pursue extended training were more likely to be CMGs at 27.8% versus IMGs. That was a percentage of 14.9%. Then for the time series, so for our time variable of year of CPSO registration, we can observe that the pursuit of extended training increases over time, which may be due to growth of seats and programs. Now for figure 1, we show here the percentage of family medicine graduates that pursued specific extended training programs here in Ontario, with the darker blue being emergency medicine, orange being family practice anesthesia, green being obstetrics, and lighter blue being enhanced skills. And now we can see that enhanced skills represented the most common type of extended training, followed by emergency medicine, family practice anesthesia, and obstetrics. Overall, the proportion of graduates pursuing extended training increased between 1995 to 2006 from 16.2 to 31.4, but remained relatively stable from 2007 to 2021, which ranged from 23.4 to 27.4. And this is the SEC standardized annual percentage of graduates who pursued extended training by postgraduate medical school. Each year has its unique color, which leads to this gradient. We applied sex standardization to allow fair comparison of extended training pursuit across years and between medical school, independent of differences in sex distribution. And on the far right, we see that Queen's University consistently had the highest proportion of graduates pursuing extended training, ranging from 28.1% to 59.4%. And if we dive deeper, we saw that those that pursue extended training at Queen's University were most likely to pursue them in enhanced skills or emergency medicine. Then for this table 2, which is the multivariate model, it is the sex stratified predictors of extended training among Ontario family medicine graduates practicing in the province. And this is the postgraduate medical school model. As undergraduate medical school and postgraduate medical school had strong collinearity, and due to that, we made it to 2 separate models. So for this one here, what we could see highlighted in yellow and bolded are the significant association. For postgraduate medical school and the sex stratified models, Queen University has significantly higher odds of pursuing extended training compared to Ssmf graduates. So in the male, it was 2.03, then here it was 5.32. There might be arguments, but more comments regarding the reference category, although Ssmf, which is the Northern Ontario School of Medicine University Family Medicine Residency Program, was only established in 2009. We selected that as the category, reference category, given its strong alignment with our rationale and hypothesis that medical school with the strongest social accountability commitment would likely have lower odds or lower percentage of their graduates pursuing extended training. We also changed the reference point to be University of Toronto, as this is the largest medical school here. However, it showed the same result for Queen's University. Queen's University consistently had higher odds across both sexes. Now, if we look at country of medical school for both sexes, Canadian medical graduates had higher odds of pursuing and completing an extended training program. Then over time, we can also see that compared to pre-2000 and a year afterwards had higher odds of pursuing and completing an extended training. And what's interesting to note for practice location, if we're looking solely to female, when compared to rural remote, it actually had lower odds of completing an extended training. We did also do on the side a sensitivity analysis where we restricted the outcome to emergency medicine, and we chose that as emergency medicine is the most common and the longest running extended training program. And there is some literature behind that those that do pursue emergency medicine tend to stay in that field. However, the results suggested that emergency medicine training is not the driving force for the differences across the schools. And then we have our last figure here, which is the final seal of the story, which is the pairwise comparisons of Ontario postgraduate medical school. So the odds ratio estimates for the likelihood of producing family medicine graduates pursuing or completing extended family medicine training. Now we can see at the, if it's red is higher odds, blue it is lower odds, and it's just a gradient just showing that. So graduates from Queen's University had the highest odds of pursuing extended training, significantly higher than those from University of Ottawa. So when compared to University of Ottawa, they had higher odds of 2.72. Then they had a higher odds than University of Toronto. It was 1.80. Then, and also they had higher odds when compared to Western University, which is 2.09. Now, I've shown a lot of tables, numbers, and figures, and we can come back to the key discussion points of this objective 1. So objective 1, the discussion points are that significant differences between medical schools highlight the role of institutional culture, mentorship, and hidden curricula in shaping resident specialization decisions. The higher participation of CMGs compared to IMGs may reflect underlying differences such as age, return of service obligation, and intended practice location. Now, lastly, these findings underscore the importance for medical school to consider the impact and context of extended training. Again, I'm not here trying to make it seem that extended training is a bad program, but we just need to ensure that this aligns with the social accountability mandates of each Ontario medical school and assess their implications for the future primary care workforce. Now, that was objective 1, and there's still more with objective 2, practice in rural remote areas. Now, for the population, it is similar to our objective 1, which is family medicine graduates actively practicing in Ontario. Again, that is 2022, with an independent license obtained between July 1st, 2017 and July 1st, 2021. Now, the time frame did change with Objective 2, as we wanted to see IMGs who are still fulfilling their 5-year return of service agreements, and that is why we changed it to 2017 and 2021. Our outcome is practice in rural remote areas, which is classified as SAC types 4 to 7. But you will see with table 1 is that we actually broke it down into large urban, small urban, semi-rural, rural remote, as we wanted to see a broader scope of family physicians practice location. Now, SAC type 1 is a CMA, which is a census metropolitan agglomeration, so large urban. Then 2 and 3 would be census agglomeration, small urban. Semi-rural are 4 to 5, given that they have strong to moderate influence from urban areas. Then 6 to 7 have weak or no commuting ties to urban centers, and this may reflect to higher isolation and greater challenges in healthcare access. And our analysis is similar. It is a multivariable logistic regression model. Now for table 1, we're showing the characteristics of Ontario family medicine graduates by practice location. Between 2017 and 2021, 2,263 Ontario family medicine graduates registered for independent practice. Of these, 235, which is 10.4%, were practicing in rural remote areas in 2022, including 147, 6.5% in semi-rural, and 88, which is 3.9% in rural remote communities. Now, in the red box, we're showing again language of practice. Highlighted in yellow are those in semi-rural and rural remote. Compared to those practicing in urban settings, a higher proportion of graduates practicing in rural remote communities were more likely to be bilingual in French and English at 15.6% versus 10.3% among English speakers and 7.9% among others. Now, if we're looking at postgraduate and undergraduate medical school, we saw that Northern Ontario School of Medicine University had, at both levels, had the highest proportion of their graduates practicing in rural remote areas. Now, for the country of medical school, what's interesting and what we'll probably discuss later is that CMGs and IMGs have similar proportion for working and practicing in rural remote areas. And what's interesting is IMGs are obligated to work in what we air quotes say underserved communities in Ontario for 5 years post their residency completion. Then lastly, type of training, which is what we saw first with extended training. So this is 2-year family medicine program, emergency medicine, family practice anesthesia, obstetric, and enhanced skills. And we can see here that emergency medicine trainees were less likely to practice in rural remote areas compared to other types of training. Now for figure 1, it shows the percentage of graduates practicing in rural remote areas of Ontario in 2022 by their postgraduate medical school. And we could see here clearly that graduates from Ssmf were most likely to practice in rural remote communities at 25.9%, followed by those from the University of Ottawa at 15.7% and Queen's University at 15.2%. If we're linking it back to the objective 1, where I said that Queen's grad were more likely to pursue extended training, I looked at specifically Queen's grad practicing in rural remote to see what type of training they had. And 57.5% had completed a 2-year family medicine program, 30% completed enhanced skills, 10% completed family practice anesthesia, and only 2.5% had done an emergency medicine program. Now for table 2, which shows the multivariate analysis, this is predictors for rural remote practice among Ontario family medicine graduates, postgraduate medical school model, highlighted in yellow and bolded again are significant associations. So if we're looking at strictly postgraduate medical school, when compared to Ssmf, all other Ontario medical schools have lower odds of practicing in rural remote areas, with the largest difference observed at the University of Toronto at 0.12. And then if you look at type of training, we are missing family practice anesthesia and obstetrics. It's due to the fact they have small cell size, and when I did the analysis, they were producing large and inaccurate odds ratio, and for that I had to group them in under enhanced skills. So when compared to a 2-year family medicine program, those that pursue an extended training in emergency medicine have lower odds of practicing in rural remote areas compared to graduates who completed a standard 2-year family medicine program with an odds ratio of 0.26. And then we have again a heat map. So the pairwise comparisons of Ontario Postgraduate Medical School odds ratio estimates for the likelihood of producing family med grads practicing in rural remote settings. We can see here that graduates from Ssmf have significantly greater odds of practicing in rural remote areas compared to those from University of Toronto at 8.19 and Western University at 2.44. Now for figure 3, it shows the percentage of Ontario family medicine graduates practicing in rural remote areas in 2022 by type of training in country medical school. So what we're specifically looking at here is the type of training. Graduates with extended training in family practice anesthesia were most likely to practice in rural remote areas at 36.6%, followed by those who completed a 2-year family medicine program, 11.1%, and head skills 8.3%, obstetrics 6.2%, and lastly, emergency medicine programs 3.1%. And we can now visually see that CMGs and IMGs have similar proportions of practicing in rural remote areas. So it was 10.3 for CMGs and 10.7 for IMGs. And the reason I say this is interesting is that IMGs are mandated by their return of service agreement here in Ontario to practice in underserved areas for 5 years. And shown through the study, this is not translated into increased practice within those communities. And that's because IMGs are not allowed to work in the GTA or Ottawa. They are, however, allowed to work at Sudbury, Kingston, London. So it doesn't really necessarily tell them that they have to work in underserved communities. They're just not allowed to work in Ottawa and the GTA. So for medical school, urban-based schools may face challenges such as limited rural rotations, training sites, and weaker rural mentorship networks, which may hinder their social accountability efforts. Differences in practice locations highlight the need for medical school to assess extended training programs in relation to the evolving healthcare needs of the population they serve, balancing the demand for comprehensive primary care and the need for specific areas of expertise. Now, it was a great project. I did a great job. I pat my back, but there are limitations. So analyses are restricted to the CPSO dataset, which are physician registry variables. It is a cross-sectional design for both studies, which limits casual inference. Registry provides only one postal code, which may not capture multiple practices, as certain physicians do work in hospitals and other clinics, but I was not able to see that. Small cell size require grouping category 1 and 2 programs as enhanced skills, and this may have mask program-specific effects. There was no linkage with admin data such as ICS, and I was unable to assess comprehensiveness of practice models, or workload. We are missing key determinants such as age at graduation, prior residence, rural upbringing, race, ethnicity, socioeconomic status, gender, motivation for career choice. And these factors are known to be associated with practice pattern and career trajectories. So future studies should address these gaps through linkage with admin data or survey data. And lastly, findings are limited to Ontario and may not be generalizable to other provinces and territories. And I will wrap up this great project by discussing the implication of research findings. So with my project, this may help guide targeted intervention for stakeholders in medical education and the health workforce through contextualized, actionable research dissemination. What we strongly want everyone to know and what I want to share is that evaluating graduate outcomes is essential to ensure that medical schools are aligning their activities with the health needs of the communities they serve, especially those who are the most underserved. And now our research contributes to long-term system sustainability by supporting improved access to care across Ontario. By examining the role of medical school in shaping workforce distribution, this project informs effective strategies to tackle the province's primary care crisis and advance health equity. Thank you.
Saredo, thank you. That was a great presentation. While people are thinking of questions and comments, I'm sure this is going to generate a lot of discussion. I just want to share a comment and a question for you. And the comment is actually last week I attended the International Conference on Medical Education, or sorry, on Academic Medicine. My apologies. And I know there were a number of people on the call here that were there as well. But one of the sessions that I attended was a joint panel discussion with the College of Family Physicians, the Royal College, and then there were some residents on this panel as well, recent family medicine residents, and it was all around hidden curriculum. I
Mhm.
noticed in the first part of your study, that was, a consideration for, an explanation of why there may be these differences. And bottom line, from that conversation, what I took away is that really, I mean, hidden curriculum is still in our medical schools,
Mhm.
still there, still alive and well. How it may be a little less overt than it used to be, but it's still there. Reason why, there is a greater understanding that there's a need for family physicians in our healthcare system, and that other specialties recognize this. But still, there needs to be an understanding that in family medicine, there is broad understanding, um, less depth, but understanding for other specialties who have a narrower scope, but a deeper understanding that when, for example, a family physician makes a referral, it's because they've reached that limit here and they need that support from the other specialists. And it's that common understanding, of how that system works that really needs to move forward. So that's just a comment, and then others may have some comments about that too. But my question is, around that first point that, well, at Queens, there's a much higher likelihood of doing a plus one.
Mhm.
Yet when I look at the second study in the rurality, you know graduates from U Ottawa, for example, and Queens, it's about the same percentage that
Yeah.
are going into rural practice. And I'm just wondering, why that may be different
Actually,
between the two schools. Yeah.
that's a great point. Just a FYI, if no one knows, Dr. Archibald was part of my thesis examination. Uh, so when I'll say this again, when I looked at Queen's grad that were working real remote and seeing exactly what type of training they pursued, it was mostly family medicine. It was a 57.4% family medicine, then 30% enhanced skills. So most likely they are taking these enhanced skills to ensure that they are aligning their skills and competency to the evolving population health needs in Kingston. But we don't know why they are taking or pursuing extended training at higher rates than any other medical school. There's this idea that perhaps Kingston have a higher ratio of specialists to family physicians in that area. That might be due. We are not 100% certain, but it's just interesting to note that although they had higher proportions of pursuing extended training, those working real remote were mostly individuals that completed a standard 2-year family medicine program.
Thank you. Bill, go ahead.
Saredo, congratulations on excellent work. And I must say you presented it extremely well today.
Thank you.
I want to focus on the part of your study that involved people taking extended skills training.
Mhm.
Um, you know, you didn't come right out and say it, but the suggestion is that somehow that is less socially
Has Bill cut out?
I think
I
so.
think
Yeah, I
so.
think the question is maybe around +1 being less socially considered,
Hmm.
less socially accountable than
So,
providing fully comprehensive. Oh,
uh, sorry,
you cut out for a sec, Bill.
yes,
Trying to finish your question. Go ahead.
the the issue of comprehensiveness is whether or not patients are getting their needs met.
Hmm.
And it's not, uh, I think, helpful to look at it at the basis, at the level of a single provider. I think it matters whether people living in a district or a region are getting their needs met. And don't, I don't think you were measuring that. And I don't think anybody knows whether even at the level of a practice, you can have somebody in a practice, you could have 8 or 10 so-called comprehensive physicians with somebody who then is focused on obstetrics or something else. And I don't think we know whether patients' needs are better met uh, um, based on the percentage of people getting focused practice training.
Hmm.
And I'm kind of sympathetic to people who do that training at the moment because they're kind of getting beaten up. Um, Obviously, there's a crisis where we need more so-called comprehensive family physicians. But I do think that people with focused skills, if they respond to the needs of their community, can be every bit as helpful in terms of responding to the needs of the community. So again, I want to congratulate you on the way you presented your work and the rigor with which you did your work. But just from the very start, I was kind of concerned about one of your objectives,
Hmm.
the way you were trying to measure it.
No, we agree as well. Sadly, since we don't have this data, we're not able to see the workload, the comprehensiveness of care. I can only see their program through the CPSO data scrape. Again, we're not here to label an extended training as a not socially accountable, since social accountability mandates are unique to each medical school. But what we are missing is whether or not this is a necessary training for the populations they serve. And that's what we're missing here. But great points. Is at the end, we had to produce a thesis. And it was an interesting topic, and it allows us to see the differences of type of trainings within our primary care workforce.
Again, well done.
I can chime in too, Bill. It's interesting because Steve Slade from the college was on this project as well, and it's something that he really reflected on too, right? Is doing a third year quote a bad thing or a not socially accountable thing? I think what we were interested, and the original study actually intended to look at actual practice patterns to link to ICS data to see how physicians actually practice. Is it like a combined practice? Can we understand, the practice volume, the types of patients they're taking care of, and because of uh, data barrier discussions around the linkage between the College of Physicians and Surgeons of Ontario and ICS, we weren't able to pursue that. But it's a great question, right? We don't know the answer. What we were interested in though is that there is variation by medical school, and so trying to understand why that is. And I think a couple of ours findings around like that people who do third year in anesthesia who then practice rural remote is compared to those who say do emergency medicine who mostly practice in an urban center. So like the argument that people are doing emergency medicine to go out and be ready for rural remote practice isn't really playing out. And then the CMG IMG is interesting too, right? So we see actually at the end of the day, in the first 3 years of practice, there aren't more international grads going into rural remote practice. And so just trying to understand, we don't understand why necessarily or have all the answers, but some curious findings that I think.
I think, Claire, that you wouldn't have got much further if you had connected into the ICES data with respect to the first of your objectives. I think you need to ask patients whether their needs are being met. That's really,
Absolutely. But we
yeah.
wanted to even look at things like if you grew up in a rural remote background, are you more likely to take care of rural patients, right? Or if you grew up in a low socioeconomic status neighborhood, are you more likely to take care of people who live in rural, underserved settings, for example, even looking at some things around immigration, but we just weren't able to do it, unfortunately. Saredo, I see
Is
Ben
there
Robert has a
Yeah.
question that you probably have an answer.
so while I understand the importance of postgrad training, I wonder if so yes, undergraduate medical school showed similar results, especially for rural remote practice. We saw the similar results with those that went for their medical schools at NOSMU. They were more likely to practice in rural remote regions. And for Queens, it was a similar association seen in the undergraduate medical school level.
Go ahead, Owen.
Yeah, just a few comments. Colleges, family practitioners have rejected 3-year licensing, staying with 2 years. That's going to have an impact. Another thing that impact would be the role of nurse practitioners and pharmacists in being able to muscle into primary care territory that they used to do before. One of my concerns is return of service, is that a lot of residents, particularly if they come from well-off backgrounds, are kind of buying themselves out of that commitment to return of service. And on a practical side, we write letters of reference for people who are going to do emerge medicine. And, this person is now kind of lost to the family medicine pool. And it's kind of sad. So
No, it's two good points there. Any comments from anyone about what Owen's just said?
I guess I would reflect back on Bill's comments that we don't necessarily know we don't need those. We need comprehensive care family physicians, and maybe we need emergency physicians. I think it begs the question of understanding the population needs, and that may be regional as well. Uh, with respect to buying out, I don't know about the buying out of the return of service. I think actually the return of service agreements are very narrow. It's really only GTA and Central Ottawa, I think, that are the locations that people aren't supposed to practice. So it's not really, I think, an incentive for true rural or remote practice right now.
Go ahead, Ben.
Thanks. This is an excellent presentation. Thank you, Saredo. I'm just curious as to how medicine is being taught, if there's an actual impact on where people go. I know that in family medicine, um, typically one has to feel quite comfortable in the uncertainty. And I'm curious as to whether we're measuring how undergrad is being taught, so that if you're taught to be perfect, and you're taught to be certain, then maybe you're more likely to have a +1 or a specialty training. And if you're taught to feel comfortable with uncertainty, which is typically what happens in rural settings, and areas where the closest CT scan is a couple hours away, I think that I'm just curious if that is reflective of what we're seeing.
That's a great question. I actually would bounce it to Claire because I have no idea how the undergraduate medical school training goes. Uh, but that is a great question.
Yeah, for sure, Ben. I think, and I don't have a perfect answer for that. I think it does come down somewhat to the concepts of hidden curriculum. Like you said, the comfort that, like, what kind of students are we attracting into medicine, right? I think we still do have a perfectionist, quite a, I think we like to think that we choose broadly, but evidence would suggest we actually don't. Um, uh, so I think there are a lot of factors that we just don't fully understand, both who we bring in and how we teach. And that's partly why we wanted to give this feedback to individual medical schools who are, currently trying to revamp a lot of them anyway, revamp their curricula around generalism and comfort with uncertainty, and promotion of family medicine as an attractive specialty. Um, so I think these are complicated, right? And there's also, of course, the policy environment that people are working in, which is ever shifting. The AFMC is a partner on this project too, so we've shared some infographics with them to look at the variation and help us maybe understand what's happening in different contexts.
Dr. Premji mentioned that the CFPC survey did show that trainees are indeed feeling underconfident, and that is one of the reasons for them planning to extending family medicine training to 3 years, which is what I've seen through literature as well when reading about hidden curricula, where certain individuals felt that 2 years wasn't enough for them, and that's the reason why they were doing plus ones. So that's completely aligning from the things that I've been reading. Yes.
Go ahead, Paul.
Saredo, that was really excellent. Congratulations. Yeah, I'm inclined to agree with you. I'm not sure that we can pin it on one thing. I think there was a really interesting article in the Canadian Family Physician this month where they looked at the gaps in between comfort levels of practice and training. And I just think this does is it may highlight how complex it is to be a good comprehensive family doctor. It's very difficult. And I think honestly, we probably don't spend enough time training people. And there's a lot of pressure now to train people more quickly. So that would be my comment.
Thanks, Paul. Owen, go ahead.
So for the Ontario taxpayer who's subsidizing a lot of medical education, etc., etc., does it make more sense for them to have money go into NOSM and have people from rural Northern Ontario go to med school rather than people, including myself, I'm a foreign medical graduate, be trained in Toronto, etc.?
That's a good question and a tough one to answer. I think we also have to keep in mind that each university has their unique social accountability mandates. So NOSAMU would focus more on ensuring that rural remote, like there is active rural remote practice. But I don't think we should change that, given that there's still a need for, University of Toronto to produce graduates that practice in underserved areas or marginalized population within the GTA. I think this is very complicated.
I think it's very complicated too, Saredo. Oh, and it's an interesting question, right? I think Sarita's got her finger on the pulse of it's really, I think, understanding the needs of the populations of the medical schools. So she is trying to do an analysis that's going to kind of estimate what the catchments might be for each medical school. NOSM is actually having their own reckoning right now. They're saying that they retain people, quote, in the north, but that actually is mostly Sudbury and Thunder Bay. And like they're having a reckoning that they're not actually getting people into rural remote settings. And we've looked at other variables too, like do francophone physicians actually practice in francophone dense areas? And in fact, they don't necessarily, because people enter medical school and then they have life happen and they make choices, right? So we're, like here at the University of Ottawa, you probably know we've changed our admissions criteria for um, admissions now with a focus on people who come from the region. 70% of our incoming cohorts will come from our own region with the hope that we will serve our own community. But I think this is something we're all really trying to grapple with within our schools. I got tired of training people to go back to Toronto, so there you go.
It'll be also interesting to see how Simon Fraser progresses, right? They have now just accepted their first cohort of medical students. And again, this is, for family medicine, for training family docs specifically. So we'll see,
Yep.
sort of see how that evolves over time.
Exactly, with a strong community focus, right?
Yeah.
They've asked people to, like, rather than emphasizing only marks and MCAT and, opening your own NGO, they want to demonstrate that people have a connection to community, whether that's through employment or through volunteerism.
Yeah.
I have to run to the train, so I'm going to say, Saredo, thank you for your presentation, and happy to, if colleagues have questions or want to see infographics about this, happy to do that. I'll turn over to Doug to wrap up. Thank you.
Super.
Thanks,
Thanks,
Emma.
Claire. Well, everybody, if there isn't any further discussion, again, I'll echo Claire's thoughts. Saredo, thank you so much. Terrific presentation. I think there's a lot of food for thought here, and I'm sure we're going to see these studies in print. So people will be able to further digest everything that you presented. So thank you very much. I'd like to say that our May grand rounds will be with Dr. Premji and Dr. Bakareth. So be sure to attend on May 28th. And with that, also please fill in the evaluation for the session. This is important as this is an accredited program. So please do so. I wish you a happy spring, and if you're able to enjoy the day today outside, enjoy. All right. We'll see you all later. Bye now.